So I don't get in trouble. I don't care.
What about these things? Yeah. I'm thinking about going to get some like Jimmy breakfast sandwiches.
That's what you
Yeah.
Those are really good.
I gotta have more than one.
But
And then it'll be probably healthier.
Wow.
I was really wondering. I didn't realize, but like I was like no sugar.
yeah, like it'll be something.
You got up and go to the election.
I knew I would have worked out protein or something. But I wouldn't do that at her.
What's up? Nothing. Kind of late this morning.
Yeah.
I'm along for the rest of it.
At least whatever the
If we were vote,
I organized some more of the last person that added to the example. So I can
Okay, I'll probably just use that then.
there's some stuff in yellow that I need to ask you about and I'm not.
Yeah, well, some of your stuff in yellow, I just added what I had.
Oh, I didn't think I did that.
Well, I was adding it, and I thought that's how you texted me, and it's like, oh, you just do the bottom half, don't worry about anything else. So I was like, oh, okay, well, I was going to add stuff, but I added something just like that I had.
It's something crazy.
Like, I mean, it was like little things. I need to get some
Red and white, like the color. Is it like the cream?
so there were cream
But is that what you want?
yeah, I think so.
So white was like the cream flavor.
Yeah.
What do you say?
See you at home.
Yeah. Oh my god.
I was trying to Oh, it's not working.
My dad has
Perfectly balanced.
from work.
Oh, my.
That's exactly what I was just thinking.
I don't know if I could force myself to buy cereal.
Oh my god. Or his spaghetti. Like,
Yeah.
oh, you mean Elf?
Yeah, but it helps like spaghetti. I don't know if I can make it.
No.
I have a spaghetti. Just pass it to me. But have you ever had a peanut butter and soda sandwich?
Yes.
They're so weird.
Yeah, my mom loves syrup. So I'll kind of weird. I guess I eat that. That's kind of weird. But I do oatmeal like with peanut butter and syrup in it, which is essentially the exact same.
Yeah, the first time I had it, I was like, why have I never done this before? It was so good. Did you mine did. It took micrometers.
That little big dog, I
And it's so long. I had to stay over there to like finish taking. Like, this is a critical update. We start as soon as possible. And then like, get it, and like 30 minutes later, it was like 14.
Oh, I did that.
The scan now.
Too awkward to start. I can't even do it. The reason I did it I'm so sorry.
Let me go over a couple of things that I failed to mention yesterday during class. First, in pathophysiology, when I was talking about the different types of inflammation, and I was talking about gangrenous inflammation or gangrene processes. One of the things that is characteristic of gangrenous inflammation when it's acute is that if you have the gangrene due to ischemia, like a blood clot that enters the circulation going to the intestines, so that part of the intestines is going to become ischemic and die. That's called mesenteric ischemia. And it's gangrenous. It's a gangrenous inflammatory process, right? You understand that? The thing that's unusual about that, though, is that, remember there are two types of stimuli that will cause viscera, pain from viscera, to come to your level of consciousness. One is distension, the other is ischemia. In mesenteric ischemia, these patients present with the pathognomonic sign is pain out of proportion to the physical findings. I mean, they come in with just this wrenching abdominal pain, but you can find nothing on the abdominal exam. You do the lab, there's nothing abnormal. So that's a pathognomonic state. Pain out of proportion to the physical exam findings, the laboratory findings, equals gangrenous inflammatory processes. Okay? Now, the second thing is that we were talking about ulcers, the bed sores, the stasis ulcers, the decubiti. What I didn't go into, and it's in that the writing to the side, but when these things are trying to heal, when you're trying to heal these things, the tissue that forms as you're trying to heal it is called granulation tissue. Granulation tissue is, if you think of the bed sores like this, it's going to start in the rim and the bottom and sort of work its way closed like that. So it's active tissue, granulation tissue. The absence of granulation tissue means that it's not going to heal it. You want granulation tissue. And granulation tissue, if you're looking at the cell types that are most predominant in granulation tissue, you can easily imagine what they would be. The fibroblasts, and if you're going to heal, you have to have a blood supply, so endothelium. Okay. The other thing is that if we switch gears to go to anatomy, I saw it yesterday in the lab. Somebody had dissected the superior constrictors and moved things out of the way. They found a nerve in there, and I failed to mention this nerve or this situation. The constrictors, and the mucosa inside the oral cavity at the top here, the cranial forces, they're voluntary, but they're actually part of the cranial nerves. The ninth cranial nerve, glossopharyngeal, provides sensation to the back of the throat. So the oropharynx, the laryngopharynx, the sensation is 9. The contraction of, so when food enters the back as you're swallowing, food enters there, you feel it through cranial nerve 9, but then the constrictors constrict to propel it south. That's cranial nerve 10. So 9 and 10 actually form a plexus of nerves around the upper, around the pharynx. Now you test those during the physical exam by doing what's called the gag reflex. So when you have your tongue blade and can you open your mouth? And you take the tongue blade and depress their tongue. You have them say ah, so you watch the uvula go up in the midline, and then you take your tongue blade and just touch the back of their throat. And what are they going to do? They're going to go, right? That's the gag. It's called the gag reflex. It tests cranial nerves 9 and 10. Right? So those are things that I was pondering last night and said, I forgot to mention that. So here we go. Any questions about anything going on? Okay. I think what we'll do is I went through these slides last night. This lecture, the next lecture would be, we're going to go through the shoulder and axillary region first. And then the next lecture is what's called the brachium and the elbow. And I think there are only like 20 slides in that. So let's go ahead and knock it all out this morning. And then go to lab. Now what I want you to do in lab is take the skin off of the both upper extremities. So you'll have to work a team, get more scalpels so you can cut through there. The only thing superficial you need to save is there's a vein that runs right here. I'll show it to you on a slide here in a minute, called the cephalic vein. That's the only thing superficial. Otherwise, the deep fascia covers all the muscles. So the skin strips off very easily, all the way down to the palm. Once you get to the palm, it gets pretty tough. The back of the hand's easy, but the palm is tough. I would go ahead and today, since I have a lot of time this afternoon, I would go all the way down to the tips of 1 or 2 fingers on each hand. Because tomorrow, the hand muscles, there are a lot of hand muscles. So remove the skin of the palm, but just remove the skin of 1 or 2 fingers on each hand. Okay? Because you'll want to see how these muscles, the mechanics of these muscles in the fingers is pretty impressive. Any questions about that? All right, so overall morphology of the comparison of the upper and lower extremities. The bottom line is you sacrifice strength and stability in the upper extremity for range of motion and quickness in the upper extremity. The muscle mass, the depth of the socket, the range of motion is very different between the hip and the glenoid cavity up here. There are very few people that can do that with their hip. The regions, in the way that you describe this, if I say something about your arm, I'm only talking about from your shoulder to your elbow. This is the arm. It's also called the brachium. From your elbow to your wrist is the forearm, or the antebrachium. brachium, antebrachium. The wrist is just this articulation point right here containing 8 bones. The carpal bones. And the 3 regions that you see up here in the front are going to be the shoulder, which is the top, the axilla, which is this portion here, and then you have the pectoral region from the front and the scapular region from the back. Very simple. If you look at the dermatomes of the upper extremity, they're very easy. If you just hold your hand out like this, 4 is the top of the shoulder, 5 is really the lateral part of the brachium, 6, 7, and 8 are 6 is the thumb, 7 is the middle finger, 8 is the little finger, and T1 is the underside of the brachium up here. It's very easy to know the dermatomes. If you look at the bones of the upper extremity, there are several bones. Understand that the scapula, we'll start with the scapula, it has 2 surfaces. The surface that is juxtaposed to the chest is called the subscapular fossa, containing the subscapularis muscle. On the posterior aspect of the scapula, the thing that stands out most is, well, really, is the spine, the large spine. The spine ends as the acromion. So as the spine is headed up this way, and there's the acromion, there's another process that sticks out underneath it that's called the coracoid process. And then at the base of the coracoid process, there's a notch. It's called scapular notch. It's right there. Scapular notch. The scapular notch has a really tight ligament that goes across the top of it, just from one side to the next. It's not indicated on this slide. On the posterior aspect, because you have the subscapularis fossa, on the back you have the supraspinatus and the infraspinatus fossa containing muscles by the same name. The articular surface of the scapula, one of them, is the glenoid cavity or glenoid fossa. It's a very shallow surface that's made deeper by a piece of cartilage that goes around it called the labrum, L-A-B-R-U-M, the glenoid labrum. And what that labrum does, if this is the glenoid here, that labrum is kind of like a donut, a hollowed out donut, like a meniscus in your knee. Everybody knows what that looks like. That's what the labrum looks like. And it makes it, the glenoid cavity, a little deeper for stability. But it's not bone, so it has some give to it. The problem with that labrum is during shoulder dislocations, it often tears. So a labral tear is something that usually produces pain, and you have to go in and fix it. Just like a meniscal tear of the knee. On top of the glenoid and on the bottom of the glenoid, there's a little protuberance. That's called the supraglenoid and infraglenoid tubercle. They serve as attachment points for upper extremity muscles. And I'll mention that later on. He also described the surfaces of the scapula. This surface here, they call it the medial margin. I like to call it the vertebral margin. That's kind of more a clinical, useful tool. The rhomboid's attached there around the vertebral, the side that's facing the vertebra. So when you have somebody coming in with muscle spasm in that area, and you can feel the muscle spasm, and I describe it as, patient presenting with nodular spasm located between the spinous processes and the vertebral border of the scapula. It says it's the rhomboids. Okay? The lateral margin, and you've got the inferior angle and the superior angle right there. What muscle comes off the superior angle of the scapula? Right, the levator scapula. Good deal. All right, now the scapula is not only articulates with the humerus, it articulates with the clavicle. And the clavicle is attached to the sternum in the front. We'll go more about that attachment, and I think in the next test block. But the clavicle of the scapula itself has no other bony attachment. It's free floating. Its only attachment to another bone, the anchored bone, is that sternoclavicular head. Otherwise, the scapula moves quite freely. If you really want to see a scapula move, watch a cat jump off the table after you do like that for getting on the table. I mean, when they land, the scapula is quite impressive. Okay? Only if your wife doesn't see you do that. Okay? If you look at the humerus has several different pieces and parts. We'll go over all of those. The humeral head is here, and there's the neck from the head to the tubercles, and there's a greater and lesser tubercle of the humerus, and a groove between them is called the intertubercular groove. The greater and lesser tubercle, and that groove, oh, there it is right there, intertubercular groove. This is the anatomic neck of the humerus. Below the tubercles is what's called a surgical neck. The humerus and the femur both have an anatomic neck and a surgical neck. And that surgical neck means that's where breaks mostly occur. And if you're going to do surgery to remove the humeral head or the acetabular, the femoral head, you go through there. You don't go through the true anatomic neck, it's the surgical neck. All right. If we go on down the humerus, there's several other pieces of part here. Oh, that's where it says surgical neck right there. You see? All right. There's a groove on the humerus that you can see on the dry bones. It kind of spirals around the humerus. That's called the spiral groove, and the radial nerve sits in that groove. In front, laterally, is the deltoid tuberosity. So if you feel your deltoid muscle right here, you can feel where it inserts on a little bump. Right about there, that's your deltoid tuberosity. When you get down towards the elbow here, this is the anterior surface, that's the posterior surface. The posterior surface is easy because it's got only one significant feature, and that's called the olecranon fossa. The olecranon is part of the ulna here, and as you extend your elbow, that olecranon goes up into that fossa. From the anterior surface is the articular surfaces with the radius and ulna. There are two names. One of them is capitulum and the other is the trochlea. These articular surfaces, capitulum and the trochlea. You can remember which one articulates with the other one by the acronym RC, like the RC Cola. Radius capitulum. That way you'll never forget. Now, above the condyles, which is what these are, the articular surfaces are called condyles. Above that is the epicondyles. So this sloped surface area is the epicondyles. The muscles of the forearm and hand arise from the epicondyles. If you do your hand like this, if you extend your hand, put your other hand right here, you can feel the extensors of the hand arise from the lateral epicondyle. If you flex your wrist, you can feel that the flexors arise from the medial epicondyle. Moving on down into the forearm bones, if we take the radius first, it has a roundish head and a small neck, a very thin neck. And then down at the distal end, there's a little prominence here called the radiostyloid. The ulna has a styloid too. You see it right there? In addition to the olecranon. If you look at your wrist right here, you put your thumb right there, and you put your index finger on that bump on the back. You're putting your fingers on the two styloid processes. And if you'll notice, your radial styloid is about 1 centimeter more distal than the ulnar styloid. One of the things when you're ascertaining whether or not something's fractured, you just look at these styloids. If you have a radial fracture, you're going to see shortening there, or radial head dislocation, radial head dislocation or fracture. The two styloid processes, if they're lined up, that ain't right. Okay? And then we'll go over the bones of the carpal bones and the phalanges tomorrow. Between the two bones, the forearm bones, there's a membrane. There's a tough membrane called the interosseous membrane. There's also a similar membrane between the two bones of your lower leg. There's a gap on each end of that membrane to allow for vessels, blood vessels and nerves to go through. The thing about the forearm, though, is that when you have the forearm like this is supination, that direction, when you take your thumb and move it laterally. When you rotate your thumb medially, that's pronation. The way you can do this motion, now the anchor points back here don't move. The olecranon and the radial head, they don't move in terms of their positioning. What you do is you rotate the radius over top of the ulna to be able to pronate like that. I think we've already been over this, the scapula floating within the chest wall. If you look at this picture right here, a couple of things stand out. One is that there's a tough ligament attachment from the clavicle to the acromion. It's called the Acromioclavicular Ligament. And if you put your hand right here on the top of your shoulder, that's the AC joint. And you can move it around. You can feel the clavicle moving against the scapula if you move it around a little bit. But there is a tough ligament that attaches the two. There's the acromioclavicular ligament there. There are also several ligaments, or two ligaments in particular, that attach the clavicle to the coracoid process of the scapula. You don't need to memorize these ligaments. I just want you to see them there. You usually are not going to injure those ligaments unless you have a violent dislocation of this clavicle. And I'll show you some of that here in just a minute. Most of the time, though, the ligament that you have to worry about is the acromioclavicular ligament here. If you can't injure these two without disrupting the acromioclavicular. You can't. Now, joints, and the shoulder joint is a good example, a representative example. The elbow, all the joints, the articulations between bones have a capsule. That capsule, inside that capsule is the synovial membrane that produces the synovial fluid. We'll really see synovial fluid when we get to the knee. It's like, kind of like oil, mineral oil. It's kind of gooey, but it has the consistency of mineral oil. But you also have that in the shoulder. So you have the synovial membrane, then you have a ligamentous capsule around it, and then you have a joint capsule. Let me just say, let me back up. You have the synovial membrane, and then around that you're going to have a series of ligaments. I'll show you the ligaments here in just a second. What they've done up here in this picture is they stuck a needle in the shoulder and they filled up the capsule with wax. And then they removed the ligaments in the membrane to show you the extent of the joint capsule itself. Okay? Notice that it's pretty large. In addition to the joint capsule, joints often will have bursa around them. Bursa are little flat sacs with a little bit of fluid in them, and you usually find them between two surfaces that rub together, like a tendon with a bone. You have several bursa in the shoulder, around the shoulder joint here, because all these muscles are attaching to the humerus and scapula. But the weird thing about the shoulder joint is all these bursa communicate with the capsule. So that all of them communicate with the joint space. That's why if I want to inject her shoulder joint, so I don't have to actually go right between the humerus and the glenoid, because all of these bursa, you see that bursa extending under the coracoid process right there? I can actually get to her joint space by passing a needle through here. I can go posteriorly underneath the acromion. I can actually go lateral between the acromion and the humeral head. So you can inject the shoulder or drain the shoulder from any of the three directions, because all those bursa connect. So the same thing, the same fluid you get out of the subacromial bursa is the same fluid that's around the shoulder joint. If I need to inject a steroid in there because of your arthritis, well, it's real easy to do. Shoulders are easy to hit. Okay? And it's really painless to inject the shoulder. Anybody had their shoulder injected? One? Okay. I've had mine injected one time. It's fine. I've injected a bunch of them. It's easy. In the cadaver over there today, I can get a syringe before you start tearing everything up. I can get a syringe with a needle on it, and you can practice sticking that needle in there and hitting what you think is the joint. Okay? I think Professor Rourke is going to come over. She was in orthopedics for a while, so she can show us some good things related to the shoulder. You'll notice this tendon right here that passes up through the intertubercular groove. There's a ligament that holds it in place. It goes up through and is actually inside the joint capsule itself. This is the tendon of the long head of the biceps. You'll see it here in just a minute. It's going to attach to the supraglenoid tubercle. Tendon of the long head of the biceps. Here's some bad things. AC joint separations. There are different degrees of separation. You can see you don't need to know these, but well, not right now. You'll see anywhere from a strain or type 1, which is just basically the ligaments are stretched, to actually disruption of the ligament and displacement of the AC joint. Here's the normal joint up here. There's a little gap that you would see there. That gap is going to be occupied by cartilage on the two surfaces. Bone doesn't rub up against bone. They have an articular cartilage that makes it less painful. But here, this is not right. That's supposed to be down there. So that's a type 3 or 4 separation there. That's pretty bad separation. That's going to need to be probably surgically, yeah, that will be surgically repaired. The other thing about the clavicle is that it's the most commonly fractured in bone in the body, and it's the middle third that is fractured most of the time. You can see this guy up here with that knot on his shoulder there. That's a nice fracture. Here's the fracture. You can see there's the fracture right there. You see that fracture is there, and then there's there as well. That's a piece. That's fragmented. A fragmented fracture is called a comminuted fracture. C-O-M-M-I-N-U-T-E-D. Comminuted fracture. That means it's in pieces. You okay? Mm-hmm. All right. To fix something like that, you're going to have to go in there and put a plate in it with screws to put it all back together. My dad, just before Christmas, he's 83 years old, he fell and fractured his humeral head, and not on the surgical neck like normal people. He actually bisected his the humeral head this way. You can see, I've got x-rays on his x-rays on my phone if you want to see them. But it's like, well, wait a minute, the humeral head's over there. You know, it's supposed to, part of the humeral head's over there. So what they did was a procedure they called a reverse arthroplasty. So normally the glenoid is here, and it's the humeral head that rotates. What they did was they cut off his humeral head and put a cup there, and then they screwed a ball to his scapula. So now the ball is on his scapula, not his humerus. But it's kind of cool.
Why did they do this instead of just leaving
it just works better. They used to always put the ball on the humerus, but somebody got the idea, hey, let's reverse it, and it works better. Most of them are done that way now.
Depends on whether you have a rotator cuff or not. So
What's that?
depends on whether you still have a rotator cuff or not.
Okay. I mean, everybody has a rotator cuff, whether or not it's injured with the fracture. That's what you're saying. Okay, cool. He's 83 years old. He may not have a rotator cuff. So, okay. Yeah.
Sorry. On the previous slide, when the ligaments are ruptured, do you have to surgically pin the bone back to where the ligaments would be to get it to grow back, or just put it in that?
I don't know if they would repair them. I don't know if they would repair the clavicular and coracoid ligaments. They would probably do something to the AC ligaments. Are you in do you have an orthopedic background? Do you know about that? We can ask Sally.
I was just curious if they'd have to pin it to make them grow together, or if they could just put it.
Most of the time, they just take wires and screw them together. I mean, attach them together.
Oh, okay.
That would.
Yeah, you can screw and put allografts in.
Allograft.
Wrap around, yeah.
Yeah, they use cadaver tendons and just all sorts of weird, bizarre stuff. Okay. I was in PA school. We were practicing physical exams on each other, and my partner was listening to my test. Hey, you got a knot right here? I fractured my clavicle at some point in my life and never knew it. Probably in high school football or something. Okay, here are the ligaments that you see here. Now, what I'll do today on one of the cadavers is I'll remove all of the tissue around the shoulder, and so you can see the cartilage, see the ligaments here, and we'll cut open the ligaments and rotate the humeral head out so you can see that actual articulation. You're going to be dealing a lot with the humeral head and these structures, so you need to get a good look at it. Here's an anterior shoulder dislocation, which is the most common type by far. Probably 90–95% of shoulder dislocations are going to be anterior. And if you look at the reasons why, one of the reasons is the rotator cuff muscles are in the front, top, and back, but not inferiorly. And the ligaments that hold the capsule in place here are found in the front, top, back, and not really inferiorly. So if you're going to dislocate your shoulder, it's going to be in this direction most commonly. Sort of an anterior-inferior dislocation. This thing right here should be up there. So anterior dislocations are quite common. They're pretty easy to put back in most of the time. On occasion, they're a little hard. Mostly, if you have an athletic person with a lot of muscle mass, they're hard to get back in because you've got to get so much sedation. It's like a TMJ. You've got to get so much sedation to relax the muscles in order to allow it to go back in. But there are several different tricks for getting it to go back in, and when it does, it clunks. It goes clunk, and you feel it. It's kind of a gross sensation.
Once ligaments are stretched out, do they kind of just stay stretched out?
If you're, well, like in the case of this right here, if you have a shoulder dislocation, you're like 50 times more likely to have it happen again. Yeah. The more you abuse a joint, the more lax it gets. So anterior dislocations are most common. Posterior dislocations are much more serious because there are a lot of structures back there you don't want the head of the humerus impinging on. A friend of mine was, we were in his backyard and he tripped and fell and dislocated his shoulder. He had dislocated his shoulder before in high school and stuff, had surgery on it. And he was lying there in pain, and so he's a physician. So we had one of the other guys that was with us go get a sheet from inside the house, and what you do is is that a scarf you have on? What you do is you take that sheet, and so let's say this shoulder is dislocated, put your arm. So here, you hold that.
Looks terrible.
So you pull, she's pulling that way, and I'm pulling this way to get it to go back to the joint. And so when I had Mark go get a sheet, he comes back out with the tablecloth that was lace. No, go get a sheet. So he comes back out. So we tried to get it back in, can't get it back in. Another thing you can do, one thing was kind of funny. When Mark was pulling that way, he got the sheet up around Bill and was choking him. And so the other thing you can do, and the reason you're pulling that way is because you're pulling so hard this way, right? It's just a counter traction is all it is. The other thing you can do is, if the sheet doesn't work, you can, since he was lying on the ground, you can lie on the ground with him and take your foot and put it in his axilla and push against his axilla like that and pull it. So we finally got it to go back into place. Well, the thing about it was, we didn't x-ray it. You always x-ray it before you put it back in, because it might be broken. Remember the guy was telling him banging it? Right. The other thing is that had we x-rayed it, we would have seen that it was a posterior dislocation, because he was really bothered by this. A few days later, he went to see the orthopedic surgeon, and his labrum was just torn all to pieces from where his humeral head just raked off of it to go backwards. So you don't do a posterior dislocation reductions that way. We got it done without any muscle relaxer or anything.
So when you're pulling it back, do you have to at some point let it fall back in, or is it going to just sink back in?
Well, what you do is when it comes out, the humeral head goes that way. And they always come in like this. They always come in like this. They can't, their humerus is rotated that way. They always come in like this. And what you do is you take as you're pulling, can we turn towards, you can feel the humeral head right here. So the way I do it is I get my finger on the humeral head as I'm pulling, because you're trying to pull it down so it'll go back up into that inferior gap, right? So that's why you're pulling down. And then I take my thumb or my fingers like this and rotate the ball back in. And when it goes in, it goes clunk. It snaps back in place.
So you're pulling on it the whole time until you feel it like pull back into that spot.
So funny.
Well, you're pushing it. You got to push it over the labrum.
Oh, okay.
You got to rotate it over the labrum. And when it gets over the labrum, it really clumps.
And would you do that with someone who you've already put stuff on to make them their muscles relax?
No, you give them oral IV medication
to relax
to
them.
knock them out.
Would you still do the same thing with a person who you've relaxed versus a person like with Bill who hasn't?
You do it to everybody.
It's the same technique no matter if they're relaxed or not.
No, you relax everybody.
Oh, you relaxed? Did you relax Bill, or was he?
No, it was in his backyard. Other than a couple of glasses of wine, we didn't have any. We just got his in by brute force. But also because he's had his shoulder dislocated so many times, it was easier to go back in. If it had been the first time, we would have been able to get it back in. It's like having a baby. Vaginal birth, the first time, it's a struggle. By the 8th time, all you sneeze and there's a baby.
My shoulder pops out.
The shoulder pops out.
It's popped out in my sleep before, and I woke up and I couldn't move it. And then I had to sit up and push it back down.
We can pull it out.
It hurts when it comes out for me. It's not like double jointed. It pops out really easily.
One more. So when people get ligament repairs, ACL or whatever, is it because there's no blood supply to ligaments to repair themselves?
There's very little blood supply to the meniscus. There is a very good blood supply to ligaments. But the reason they don't heal by themselves is because ligaments and tendons by themselves are nothing but fibroblast structures. They're very dense structures. So you can't really take very dense structures and get them to grow together. You can, it takes a long time. Like you look at a bone. It takes a long time for two pieces of a bone to grow together. Most of the time you're going to assist them by putting a wire through them or some type of graft. Put another ligament in its place and suture it to both sides. Or a lot of times they'll do tendon transfers. They'll make ligaments out of tendons. They do all sorts of bizarre stuff. The pectoral region is shown here. The muscles in the pectoral region you're going to find is the deltoid muscle that overlies the top of the shoulder, and then anteriorly you have the pec minor, and overlying that is the pec major. The pec major arises from the clavicle, the sternum, and a bunch of ribs, and will insert into the humerus. The pec minor is underneath it. It arises from just the ribs, a few ribs, and it inserts into the coracoid process. It's one of the three muscles that inserts into the coracoid process. One of the muscles that is really inconsequential, not clinically relevant really, is the subclavius muscle. It's a small muscle up here, right up under the clavicle, helps hold it down. It's attaches, runs from the rib to the bottom of the clavicle. I actually have seen one of the cadavers. You have a very nice subclavius muscle. I don't remember which one it is, but it's very prominent. And one of the things we want to do today to help expose the area is use that bone saw to cut the middle third of the clavicle out. And that opens up the posterior triangle, which is the continuation into the upper extremity. The deltoid muscle has three different components to it, whether it's attached to the clavicle or the acromion or the scapular spine. So depending on what part of the deltoid contracts, it either will extend the shoulder, it'll flex, I did that backwards, flex the shoulder, extend the shoulder, or abduct the upper extremity. But realize that when you abduct the upper extremity and hold your scapula steady, the deltoid has no action above 90 degrees. In order to get above 90 degrees, you have to rotate the scapula. Because once you get to this point, the deltoid's straight across. The rotator cuff muscles, there are four. They're called the acronym SITS muscles. And the reason these are important is because you see that where their attachments are on the humeral head, they support the joint. They're outside of the ligaments of the joint, but they're supporting the joint. And the four muscles are indicated right here. The most commonly injured rotator cuff muscle is the supraspinatus. It's also, if you have rotator cuff tendonitis, it's the one that's most commonly involved. And one of the tests for rotator cuff muscle integrity is called the empty can sign. If you hold your hand out like this, straight out like that, and your thumb is up, and like you're holding a can, and then you empty the can, and you've got pain up here, that's rotator cuff. Innervation of the muscles or of the upper extremity is via the brachial plexus. The brachial plexus arises from C5 to T1. And there are different components of the brachial plexus that we can go into here. Starting off the spinal cord, you have the roots. In other words, they're the ventral primary rami.
I have a question about the rotator cuff here. I just saw that. So my dad thinks he has a rotator cuff injury, and it might have happened maybe years ago. Would it still hurt if he did that, or is that just?
If he's still bothered by it, yeah.
So it still hurts when he goes to.
Yeah, just Googling, I mean, texting and telling you to do that either way.
Okay.
Okay? So when the dorsal and ventral roots, or the ventral primary rami essentially, form what are called the roots of the brachial plexus. The ventral primary rami are the roots. What? Okay, next. If you go laterally, you get the upper, middle, and lower trunk. So that's what I tagged the other day with that upper trunk. You find these between the anterior and middle scalene. Distal to that, the trunks break into divisions. Each trunk will divide into an anterior and a posterior division. These divisions come together to form the cords. The three posterior divisions form the posterior cord. The anterior divisions will form the lateral and the medial cord. Past the cords, you find the branches, the named branches. These things are wrapped around the artery in the area right here. The vein is outside of that, so the axillary vein. And unfortunately, this area, this entire area is filled with fat. But it's easy to get that fat out of there if you just, use your hand or use an instrument and soften it up and move it out of the way. You don't need to, don't dig in there hard, but if you just gently scoop it out, it clears up really nice. Okay? So we've got roots, trunks, divisions, cords, branches. There's an acronym for that, and I don't remember what it is. You do?
The one that I was going to Travis drinks cold beer.
That sounds like a good one. Okay. So here is the detail on the upper extremity muscles here. That not all of it, just the ones between the body itself and the humerus. I don't care that you know this. General origin of insertions is all, and you've been through most of these already anyway. I don't care that you know that the pectoralis major arises from the third, fourth, and fifth rib. Just know that it arises from the ribs. It's underneath the pec minor and inserts on the coracoid process. That's it. The blood supply to the upper extremity is, let's do this and then we'll take a break. It is like the nerves in stages. We've got the subclavian artery. Did I say the nerve supply? It's the arterial supply. The subclavian artery we know. Once the subclavian artery passes the first rib, it changes its name to axillary. Once the axillary artery passes the teres major, it changes its name to brachial. Once the brachial reaches the elbow, it divides into a radial and an ulnar artery, so named. If we look at this illustration here, this helps a little bit more. Remember our thyrocervical trunk up here? Thyrocervical trunk, we did not find it in the first test plot, but you need to find it now. And when you take out that middle third of the clavicle, it's right there behind that. Because there are two branches that are important for the upper extremity. The transverse cervical, which supplies the trapezius and the rhomboids. But more importantly, well, the transverse cervical is important. Also important is the suprascapular. Transverse cervical and the suprascapular are right there in the posterior triangle of the neck, right behind that middle third of the clavicle. I'll show you why they're important here in just a second. Now, if you look at the actual branches off the axillary, here they are. First, you have the supreme thoracic, or superior thoracic, they call it. This is a tiny little artery that supplies the first intercostal space. If you find it today, great. If you don't, I'll never tag that artery. Just beyond that, and right behind the pec minor, and what you're going to do with the pectoralis muscles, you're going to cut them off the chest and reflect them up. So it'll still be attached to the coracoid process, as you see here. But right up underneath it is another trunk called the thoracoacromial trunk. That has four branches that go to the four areas that we're talking about. Acromial, deltoid, pectoral, and clavicular areas of the shoulder. You don't need to find the little branches because they're more than likely going to be cut. Going a little bit more distally is a lateral